and then we are going to talk about mediastinal radiotherapy and cardiac toxicity in patients with lymphoma. And the discussion of mediastinal radiotherapy and cardiac toxicity will be in charge of Angelica Molin. Sorry, I can't progress the
slides.
I can't progress the slides. Just a moment, please. Andrés.
Yes.
Andrés, no puedo progresar las filminas.
Wait a minute.
One second.
You can see?
Yes, but I can't.
Eric, you can see now the next slide?
I should be able to in a minute. Right now, I see the introduction slide.
If you can put me to make the presentation in the I can change the slide. So if you want, me and Ezequiel, say me when if you want to change the slide.
Hang on. Okay, I've switched you to being the presenter.
Okay,
You are now the presenter.
You can see my front
desk? I can see it.
Yes. Okay. You changed it.
Yes.
Good job.
Yes.
Okay. Ezequiel, dime, y Angélica, me dicen cuando les cambio, ¿sí?
Okay. Well, we are going to present a clinical case. It's a woman of 70 years old with an oncological diagnosis of right lung cancer. It is an stage 3A, G3, N2, M0 with an undifferentiated squamous carcinoma. She has as antecedent a chronic obstructive pulmonary disease without treatment, and she is current smoker of 50 back years, but without any other antecedent. And as previous oncological history, she had a Hodgkin lymphoma, stage 2A, 20 years ago. The patient was treated in other institutes, and she had mediastinal involvement, and as treatment, she did chemotherapy and radiotherapy in mediastin. The treatment schedule was a ABBD schedule that consists in doxorubicin, vinblastine, bleomycin, and dacarbazine. And the radiotherapy dose was 40 grays. You can change the slides. Okay. The actual oncological history, she started with cough in August of 2017. So that a chest radiography was done showing a right lung tumor. Then a tomography was done, and then a PET-CT, where a right lung tumor with ipsilateral mediastinal adenopathies were seen. The tumor was located in the upper lobe, and the lung biopsy was done showing an undifferentiated squamous carcinoma. In October of 2017 was the first time in our institute. Another tomography was done showing in upper right lobe tumor of 28 per 22 per 12 millimeters in contact with mediastinal pleura that retracts adjacent structures. And also there were right mediastinal adenopathies concordant with the PET-TC of 12 per 15 millimeters and 20 millimeters. And an echocardiogram that showed a left ventricle ejection fraction of 55%. You can continue. Well, first, the patient refused to any surgical treatment, so the therapeutic strategy was carboplatin plus concurrent radiotherapy with a dose of 50 grays and 10 grays as boost, ending in January of this year. Continue. Well, more or less 10 days later, the patient, after finishing radiotherapy, the patient started with edema in lower limbs, 6 to 6, with bilateral involvement, dyspnea, bilateral crepitant rails, jugular engorgement, and a weight gain of 10 kilograms. Continue. So the initial clinical interpretation was congestive heart failure. Continue. Well, this is the electrocardiogram at first diagnosis, where we can see ST depression from V2 to V6. The patient was studied with troponin with negative results. An echocardiogram that showed left ventricular ejection fraction of 19%, diffuse global hypokinesia with basal, lateral, and apical anterior predominance, etaps of 14, and mild mitral regurgitation and mild tricuspid regurgitation. Continue. Well, with this diagnosis, we start treatment with intravenous furosemide, dioxin, eplerenone, and sacubitril valsartan. After a clinical improvement of heart function and negative fluid balance, the patient we added to the treatment bisoprolol and atorvastatin. The patient evolves well and leaves the hospital in the 15th of April. Continue. And she has, in May, another echocardiogram as control that shows left ventricle with moderate to severe impairment of contractile function with a left ventricular ejection fraction of 35%, global diffuse hypokinesia with lower basal segments predominance, mild mitral regurgitation, and mild tricuspid regurgitation, and an NHA classification for heart failure class 1. This is the clinical case.
Good morning. My name is, good afternoon. I don't know what time is it there. My name is Angelica Molina. Like Andres already said, I am a radiation oncologist at the Institute of Oncology Angel Rojo, and I also work at the Italian Hospital of Buenos Aires. We would like to make a brief comment about radiotherapy in Hodgkin lymphoma, in mediastinal Hodgkin lymphoma, because in the patient that Ezequiel previously discussed, she has a lot of cardiovascular risk factors, such as she is a heavy smoker, and she also received chemotherapy twice with anthracyclines 20 years ago, but she also received radiotherapy in the mediastinum in 2 opportunities. Probably the radiotherapy that she received 20 years ago has a major impact in the cardiac heart failure that she developed after the second treatment. So, the next slide. Patients with Hodgkin lymphoma have a high cure rate. Around 90% of patients will be cured. Long-term survivors of the disease are at the risk for late effects. And when we treat the mediastinum, we think in 2 important late effects: second malignancies like breast cancer, and also cardiovascular disease induced for radiation. Cardiovascular disease is the most common non-malignant cause of death in patients with Hodgkin lymphoma. And the spectrum of radiation-induced heart disease includes coronary heart disease, pericardial disease like acute pericarditis, delayed pericarditis, pericardial effusion, congestive heart failure like our patient, valvular heart disease, cardiomyopathy, and any type of arrhythmia. But why the radiotherapy causes so much damage in the heart? Probably because radiotherapy induces a chronic inflammatory state in the heart, and cause several micro and macro angiopathy similar to atherosclerosis. In Hodgkin lymphoma, we still use the Ann Arbor classification, a modified Ann Arbor classification, especially after Lugano Convention in 2013. But when we talk about Hodgkin lymphoma, we talk about early stage and advanced stage. In early stage is when the disease is in one side of the diaphragm, and when we talk about advanced stage, we refer that the disease is in both sides of the diaphragm, or there is a diffuse extranodal involvement. But next slide. Andres, next slide. Okay, thank you. In classical Hodgkin lymphoma, even in early stage with favorable prognostic factors, radiotherapy is one of the main modalities of treatment in combination with chemotherapy. Chemotherapy that always include, or at least, an anthracycline scheme. Next slide, please. And in early stage also with an unfavorable risk factors or bulky disease, more chemotherapy and a higher dose of radiotherapy is also part of the treatment. And in advanced stage is the same, 6 cycles of chemotherapy in combination with radiotherapy would be a therapeutic strategies nowadays. Because of that, we have to take in mind that in Hodgkin lymphoma, radiotherapy at some point of the disease will be part of the treatment. Even next slide. In histologies with better prognosis, like nodular lymphocytic predominant Hodgkin lymphoma, radiotherapy is not only one of the modality of treatment in combination with chemotherapy, but also could be the only modality of treatment. So we need to know that patients who receive radiotherapy are in risk to develop some toxicity related to this treatment. Next slide. But radiotherapy in lymphomas is not what it used to be. Nowadays, we use the involved site radiotherapy, and we use 3 major guidelines to help us to define the size of the field of treatment and the total dose in order to protect the normal tissues around the tumor, surround the involved node, the involved site, or the involved extranodal organs. Next slide. So what happened with radiotherapy along the years in lymphoma, and especially in Hodgkin lymphoma? In the 70s, we used the total nodal approach. Was a really big field of treatment, and nowadays we are using the involved site approach, or even the involved node approach. We are using smaller field with a smaller amount of dose. So this is really important, because with a smaller field and a smaller amount of dose, we could control the disease as in combination with chemotherapy, as good as we control the disease with a massive field of treatment. So this is important because we are using this approach, and when it's possible, we use this type of treatment. Next slide, please. But why we are doing it now and not done it before? Because today we have PET-CT, and PET-CT is essential for defining appropriately the field, the size of the field of radiotherapy, and we need to have the pre-chemotherapy PET-CT, and then we need to have the post-chemotherapy PET-CT. in order to define the size of the field in length and in width, and in order to define also the final dose that we want to achieve in a specific patient. So involved site approach in radiotherapy and involved node approach is only possible when we have a PET-CT to guide our work. Next. In terms of techniques, we not only reducing the size of field and the dose that we prescribe to patients, but we also are doing now more conformal techniques like 3D conformal technique and like IMRT, which is intensive modulated radiotherapy. These both techniques work with photons, and these techniques are really suitable to protect heart and other normal tissues around the volume of treatment. So we are reducing the field, we are reducing the dose, and we are conform better the type of treatment. We are not using protons here because we don't have protons available yet, but it's also a really good option. Next. So everything that we know about the effects of radiation in the heart, we know from two main populations, early breast cancer patient and patient with Hodgkin lymphoma, because these two pathologies have a high cure rate. That means that patient will live several years after treatment and have the opportunity to suffer from some long-term effects of radiation. And what we know about radiotherapy in Hodgkin lymphoma, in mediastinal radiotherapy for Hodgkin lymphoma, is that all deaths occur in patients with mediastinal dose higher than 30 grays. We also know that all patients who develop coronary artery disease had at least one traditional risk factor. And we know that if we give to the patient a lower radiation dose in a smaller field size, and we try to abbreviate chemotherapy, we could reduce significantly the cardiotoxicity. PET-CT is also really important to try to abbreviate chemotherapy, because with an interim PET-CT with a Devil score 1, 2, or 3, we tend to think that we could reduce the number of cycles of chemotherapy. Next slide. Our experience in mediastinal radiotherapy in Hodgkin lymphoma. This is a single institution retrospective analysis of 61 patients with mediastinal Hodgkin lymphoma, stage 2 to 4, referred to radiotherapy after chemotherapy with ABVD scale. From January of 2013 to December of 2017. We start looking from that date because we start to using involved site radiotherapy based on PET-CT in 2013. The mean age of patient was 28.2 years, and as I said, we use the involved site radiotherapy technique using a 3D conformal technique or IMRT. The dose prescription was, the mean dose prescription was 31.6 gray, and 2 of the 61 patients have previous radiotherapy, one in the breast side and the other one in the left neck. And no traditional risk factor was referred or recorded in the clinical history. Probably we have some lost data here, but we also have to take in mind that these patients were very young, so probably that explains why we don't have traditional risk factors referred. All patients that are under tracing have been referred to cardiology after completed the treatment. Next slide, please. I want to show you this particular case. This was a really difficult one. In this patient, she's a 29 years old patient with mediastinal Hodgkin lymphoma. with an extranodal involvement of the sternum. So we have to cover not only the mediastinum, but also the sternum in the clinical target volume. We thought that 3D technique is more suitable for her because we want to protect both breasts to receive a significant amount of dose in order to prevent the possibility of second malignancies. So IMRT, it was not a good option for us considering that. But with 3D, we think that we could achieve a reasonable plan. Next slide, please, Daniel. The CTV is near to the heart, and it was difficult to protect the heart, even with a high conformal technique using a PET-CT to find the volume of treatment. Siguiente. Next. This is a DVH. This is a dose volume histogram. In here we could see that the clinical target volume, the volume that we want to cover with the 100 with all the dose is really well covered. But this pink curve is the curve of heart. Heart in this patient received a maximum dose of 30 gray and a mean dose of 13 grays. According to Quantec, this amount of dose that she received implies a risk of cardiotoxicity around 10 to 15%, which is acceptable, but it's not desirable. Next.
Wait a minute, because I have a problem now. Just a minute. So,
Okay,
yes, yes. Okay.
Okay, yes. In summary, mediastinal radiotherapy and anthracycline chemotherapy are the highest risk for developing cardiac disease, which may be asymptomatic in many patients. The risk of cardiovascular complication after modern radiotherapy needs to be defined. We tend to believe that if we give to the patient a lower dose in a smaller field with a more conformal technique, we are reducing the probability of cardiovascular complication. But for example, in the previous case that I show you, the patient with a smaller field, the smaller field that we could treat with a high conformal technique and with a PET-CT using in the process of planning, we give to the heart a considerable amount of dose with a high risk of cardiovascular toxicity. So modern radiotherapy needs to be defined in terms of the possibility of cardiovascular complication. Radiation oncologists should operate on the principle that there is no total save to the heart. The heart, any gray that we gave to the heart is a probability of develop some cardiovascular complication, and we have to take that in mind when we are planning our patients. Keep the heart dose as low as possible. Should be always be our goal when we are planning a treatment for Hodgkin lymphoma, which are long-term survival. Next slide, please. In the NCCN guidelines version 2018, they recommend that all patients who underwent to radiotherapy in mediastinum for Hodgkin lymphoma has to be referred to cardiology, and they recommend an annual blood pressure monitoring, even in asymptomatic individual, with an aggressive management of cardiovascular risk factors, and probably a baseline stress test or echocardiogram and carotid ultrasound for patients treated with radiotherapy, for example, should be considered at 10-year intervals after completion of treatment. Next. Thank you.
thank you very much for the presentation. I would like to ask a couple questions, and one is would you think that proton beam therapy can give you less exposure of the heart if you use that? Could you address proton beam therapy as giving less heart exposure?
Yes, proton therapy would be really helpful to reduce the dose in the heart. We have some problems with protons because protons are very sensible to the movement of internal organs. So in targets really near to the heart, it's difficult because the heart beating could be a problem for us, and also the breath movement could be a problem when we treat the mediastinum. But yes, protons are really suitable, and probably in this type of patients with a high cure rate, with a probability of cardiovascular complication, will be the most suitable technique.
Let me ask you, did this patient have any coronary artery disease by any of the tests? Was there any information about coronary artery disease in this particular patient?
We make a test of ischemia before to start the treatment, and the ischemia in that test. So we know because he has the radiotherapy 20 years ago. We try to case didn't have coronary disease, so we make a SPECT, and this is negative. It was negative.
Thank you. Joe Carver, do you have any comments?
Yeah, can you hear me?
Yes, I can.
Yes.
Oh, good. So
Yes.
I thought that was excellent, and I thank you guys. So I have one comment that is a little bit different than what we usually talk about, but I think important as cardio-oncologists, and that's the pulmonary effects of bleomycin with ABVD treatment of Hodgkin. So we're pretty aggressive about dropping bleomycin after 2 doses if there's a response. Studies that show that bleomycin doesn't add that much extra beyond that, and that the combination of bleomycin and mediastinal radiation enhances bleomycin pulmonary toxicity, which may be more devastating than the cardiac effect, so that we should all be aware of that.
Okay.
Eric?
Are there any comments about bleomycin and radiation exposure? Do you have any comments, Andreas?
Sorry, but I don't hear very well the ask of Harvard.
Not particularly about bleomycin. If we have some information about pulmonary toxicity caused by bleomycin, we try to avoid the entrance of the dose through the lungs. So we try to protect the lungs better, but we don't need a functionality test or spirometry or something like that. We don't need that before starting radiotherapy. We only think that if we have some toxicity in the lung, we have to avoid to irradiate the lung as much as possible.
Very good. We used to have more damage to the main left and the left anterior descending then lately, it seems with shielding the heart, more damage seems to be in the distal LAD and the distal diagonal vessel. Would you say that's a fair approximation?
In breast, for example, in early breast cancer, when we do a 3D technique, the part of the heart that is exposed to the dose is the apex of the heart, and especially the coronary, the coronary artery. So, but nowadays we use a most conformal techniques like IMRT, that implies that we use many fields with an exit dose that probably irradiate other parts of the heart and not only the apex. So we reduce the maximum dose of the heart, we reduce the mean dose of the heart, but we expose more part of the heart to the radiation. So we are giving to the entire, in some cases, right? But we are given little amount of dose in a more in a bigger volume of the heart. So probably because of that, you are seeing auricular problems or valvular problems, or not only in the apex of the heart or in the muscle or in the anterior descent artery. I don't know if it was clear, my response, but.
Very good. Well, thank you very much. Do we have any more questions? Calvert, do you have any comments you'd like to make?
Yeah, I think that this entity of previous exposure in the patients who have been treated in the past for lymphoma is really not appreciated in the general community, and it's not appreciated in the hospitalized patients by many of the staff. It seems to be ignored, and I've been impressed in the short time that I've been involved in this field, the number of patients who have just horrible results from their previous therapies back 20 years ago. And a lot of these patients don't even realize that they're getting into difficulties. And we don't seem to be doing a good job of teaching the community or the physicians.
Yeah, from the patients that were treated years ago, we seem to feel that most of them have a chance of getting main left coronary artery fibrosis and proximal LAD. So we've been very careful with that group of patients, and they can also get osteal disease of the main left. And so I think, as you know, I'm pretty committed to coronary CTA, and coronary CTA is very useful before we go jamming a catheter into the main left or into the left coronary cusp. It's been very useful to see what the anatomy looks like from the coronary CTA and to study the main left in more detail. Sometimes we don't even need to proceed with the cardiac cath when we get the information on the coronaries if there's severe osteal main left disease, and then we can calculate the FFR from heart flow, and then we have all the information we need. So that's one of the things that we factor in is osteal main left disease and the risk of cardiac catheterization with that on patients with Hodgkin's that had the radiation years ago. Holly, do you have any comments? Holly Weisenhahn?
Yes.
Not particularly. I think you've covered it.
Okay, thanks, Holly. Jody, any comments? Patricia, Marcelo, Joshua.
Hi, this is Patricia
here we have
Guerrero.
Dan. Dan, hey, I'm missing you, Dan. Let me get you unmuted. And I lost you, and now you're back again. So, Dan, go ahead and comment. I just unmuted you.
Hey, Eric.
I'm so sorry.
Thank you. Yeah, I was, trying to raise my hand, but you know how that goes.
I see your hand raised, and I had lost you, and then you came back. So I had muted you the first time, and now I didn't realize you came back. I'm sorry.
No problem. Thank you. So now that was an excellent presentation. I appreciate you guys getting that ready. And of course, I know that you're really excited about one day from today when Argentina will play their first match, and hopefully Messi will get a hat trick. So I just want to make sure you know I have my jersey on, so I'm all ready. But it's kind of interesting that I had a patient yesterday who was being treated for metastatic pancreatic cancer, and she had been treated for a number of years now, 5 years. And the first year that she started treatment for her pancreatic cancer, she had surgery and they felt like it was somewhat in remission, so she didn't get treated for a while. And then back in August, she had a recurrence and was placed on gemcitabine, and then starting in January, they added pembrolizumab for as a checkpoint inhibitor. And she is doing okay from a cancer point of view, but then she presented just in May for heart failure. Her EF is normal, but she had evidence of heart failure and also a pleural effusion on the right, and they did a thoracentesis. And the only reason why I'm bringing all this up is that they discussed all of these things in the context of pancreatic cancer and then, of course, the checkpoint inhibitor, but it wasn't even really commented on at any point that she had been treated for Hodgkin's disease in 1981 with radiation, and she got radiation to her upper abdomen, right exactly where her pancreatic cancer was. And then she also had mantle radiation for, disease in the chest. So she had a significant amount of calcification in her aorta, and some evidence of radiation-induced lung damage in her right and left apices of her lungs. And so the really fascinating thing is that, it's amazing, but, I know that as was presented today, many of the radiation therapy that is done for Hodgkin's or non-Hodgkin's lymphoma certainly has an important role in, and they are much more focused as was presented today. But, the thing is how important that was historically. It certainly got rid of the cancer, but the vascular and valve complications that come up 20 or 30 years later are really complex and difficult. So I think that, that's probably the biggest message from all of this is that, when a person was treated in the past for Hodgkin's with radiation, it has so many major impacts. So that was probably, just a really important point that you guys brought up today, that the current treatment may not be as difficult as the historical treatment, that's for sure.
Thank you, Dan. Dr. Ping, do you have any comments about Hodgkin's lymphoma, radiation, chemotherapy, later lung cancer? We sort of lost Dr. Ping here. She's self-muted. Any other comments from anybody? Thank you very much, team, for the great presentation from Argentina. And we're looking forward to some wonderful soccer coming up soon, as Dan alluded to.
Yes, the World Cup starts tomorrow. So.
Okay, well, I guess Dan.
Great presentation. Thank you.
All right.
Thank you so much.
Good. Thank you guys so much.
I don't think you'll be able to get Dan for a while. He'll be watching the World Cup every day. So hopefully we'll carry on for you, Dan. We'll carry on.
All right. Sounds
Dr.
good.
Ping, you had a question, Dr. Ping? Marcelo, did you have a question? Marcelo Cavalcante? Okay, well, they had their hands up, but apparently there's Patricia, you had a question?
Thank you. Good morning, everybody. And I also want to say it was a great presentation. But I also wanted to emphasize the lack of awareness amongst the medical community and the cardiology community about the importance of surveillance. So about 3 years ago, a statement from the ACC did come out in reference to the appropriate monitoring of patients who have received chest and neck radiation, including screening stress testing, even as early as 5 years after radiation. So I think that's something that we need to advocate, and also perhaps part of our screening questionnaires to all patients with a prior history of cancer is to ascertain, did they receive radiation? Because many of these patients were children or young adults at the time, and now we're seeing consequences of not only coronary disease, but severe valve disease and aortopathies as a result of it. So I think greater awareness is very important.
Thank you so much for your comments, Patricia. I appreciate it. So we do want to again emphasize that we're planning ICOS coming up in September 27th in Tampa, Florida. And so make sure that you've submitted your abstracts and registered, and we're looking forward to being your host here in Tampa. So thank you so much from our southern South American neighbors. We really appreciate your presentation. It was very sophisticated and very elaborate, and we hope you will present again next year. Thank you so much, everybody, for your attendance. We look forward to next month. Bye-bye.
All right.
Okay.
Bye.
Bye, Joe, Joshua, Marcelo, Patricia, Dr. Peng.
Hi, Andres.
Holly, Albert, Barry. Bye, folks.
Thank you. Goodbye. Have a great week.
Bye, everybody.
Andres.
And Dr. Molina for the presentation.
Adios, Andres. Adios.
Well,
Bye. Muy bien, ¿eh? En el Tarzanito.